We will now begin our next panel for this afternoon, ensuring last mile delivery of healthcare, role of CSR in technology and model building. The year 2020 has brought an all-encompassing focus on healthcare. With the COVID pandemic hitting our health infrastructure hard, technology has quickly emerged as a way to combat these challenges. Whether it be sophisticated app-based tracking system for COVID patients and at-risk individuals, or DNA-based rapid COVID tests, technology in healthcare has led to some groundbreaking innovations. While the applications of technology in healthcare are innumerable, last-mile delivery still remains a challenge. With less than one doctor per 1,000 population in India, our primary healthcare is crippled with systemic problems. Problems are the wonders of technology can work to eradicate. So join us as we explore the role of technology and model building in ensuring the last mile delivery of healthcare. To moderate this session, I would like to invite Mr. Arvind Kumar, Senior Advisor Strategic Partnerships at USAID. Mr. Kumar has over 25 years of experience in the development sector and has managed over $100 million worth of development projects. In his role as a strategic partnership advisor, he works closely with policymakers, private sector decision makers, and leads the effort for transfer of promising Indian healthcare solutions to other countries. Lovely to have you, sir. Our first speaker for this session is Mr. Prabhat Kumar Sinha, Head of Policy, Patient Advocacy and Communications at Novartis Oncology. With over 18 years of experience of working in the public health domain and managing partnerships with governments, patient groups, and industry associations, Mr. Sinha truly believes that empowering patients is the most critical task today. In addition to India, he also leads patient advocacy functions for oncology in Asia Pacific region. Lovely to have you, sir. Our second speaker for this session is Mr. Sanjay Mariwala, Executive Chairman and Managing Director at OmniActive Health Technologies. Mr. Sanjay is known for his astute vision and thought leadership. He has been instrumental in positioning India's nutraceutical industry on the global map along with developing the domestic market. He's currently the chair for the Nutraceutical Subcommittee of FICCI and is also the founder president of the Association of Herbs and Nutraceuticals Manufacturers of India. Lovely to have you joining us, sir.
Thank you.
Our final speaker today is Mr. Ranjeev Sharma, Head of Compliance, CSR, Pan India and Sri Lanka region, Marks and Spencer, India. Mr. Ranjeev is a supply chain risk mitigation specialist and a CSR generalist who has more than a decade of experience. Having worked in both corporate and development sectors, he brings in a unique perspective on resolution, addressing of issues that are prevalent in the garment sector. Currently working at M&S, he is responsible for ethical sourcing, sustainability, and CSR for India and Sri Lanka. Thank you for joining us, sir. I would like to once again remind all our panelists that this session runs till 4 p.m. Please reserve some time at the end for Q&A from our audience. I would also like to apprise attendees of this parallel session running on track B, which is focusing on enabling circular economy and waste management. This session has a great roster of panelists across the sustainability industry, and if you wish to join, please navigate to track B on the Hubeler dashboard. Over to you, Mr. Kumar.
Thank you, Yamini, and good afternoon to all of you, panel members, as well as the participants in this session. Thanks, Yamini, also for introducing us, me, as well as the panelists. I'll be a moderator for the session. This is, as Yamini mentioned, this is going to be a 45-50-minute session. We'll spend a lot of time discussing with our experts on different aspects related to last mile delivery, CSR, as well as technology, use of technology, and keep up about 5 to 10 minutes time for question and answer sessions from the participants. Just to give a quick round of a brief introduction about me. My name is Arvind Kumar. I am with USAID. Many of you would have heard about USAID, but for those who have not heard about USAID, we are a part of the US government. We are the lead agency for the government of the United States in development programs. We have been working with the government of India for over 70 years on various healthcare and other development issues. So with that brief introduction, and health is a big portfolio for us, whether it's eliminating TB and supporting the government of India's agenda, or ending preventable maternal and child deaths, or HIV/AIDS-free generation, primary care, and now COVID. All this has become a huge priority for USAID. As Yamini mentioned today, last mile delivery has been a big challenge. And I think a lot of efforts has been put forth by the government whether it's the Ayushman Bharat, whether it's the health and wellness centers, whether the frontline workers at the last mile. There's a lot of efforts which has been put forth by the government of India as well, and various state governments too. But I think the challenge is daunting. Reaching 1.3 billion people with a range of healthcare services, both primary as well as secondary and tertiary, is going to be a major challenge to the country. So this is where I think the critical role of civil society as well as private sector organizations come. And today, with technology really becoming a game changer, that's going to be a big help for us to reach these populations. So I'll stop here. Maybe I'll just start with a very opening question to the panel members, all three of you. Um, Last mile is actually defined in different ways to different people. Some say reaching the last village is what we say as last mile. Some say, okay, reaching to those people who have never been reached, like the tribals or people who are migrating and are moving. Reaching them is going to be the biggest challenge. So, according to you, all three of you, the panel members here, can you give us a very brief update on what do you think as the last mile, according to you and your programs and your organization, and identify at least one critical challenge in last mile delivery of healthcare services? I'll start with Mr. Prabhat Kumar. Maybe if you can start with this, and then we can move forward with further questions.
Thank you, Mr. Arvind. And it's an interesting question. And I think, so my name is Prabhat. As I said, I work with Novartis Oncology in India, and I lead patient advocacy, policy, and communications for Novartis. And those of you who know Novartis, Novartis is a global healthcare innovation company. And in many non-communicable and communicable disease, we have a lot of therapies. But apart from drugs, as a corporate responsibility initiative and also as a patient-centric company, we also have been doing a lot of work to improve access and care for the patient. Now, what you said about the last mile, it is a very relative term. And I think COVID-19 has redefined what the last mile has to be. What used to be the last mile, for example, if I talk about cancer care, earlier, if I used to go to a particular point for cancer care, now that same point of care is inaccessible for me. So the last mile has been redefined in COVID-19 time, and has kind of given more re-emphasis that this last mile or the decentralization has to come very close to community. Now, for me, the last mile is a point of care which is accessible to me, and it is going to be different for different disease area. It is going to be different for different individuals. And in today's discussion, I just want to be on focused. I'll be taking one disease area, which is an example, which is going to be sickle cell disease, a disease on which not many of us discuss. It is a disease with which almost 14 lakh people in our country, and mostly in tribal and backward areas, people are there. Now, for these tribal population, the last mile connectivity may be a little different compared to a person who is, looking for care for breast cancer. So it's a point which is accessible for me is the last mile.
Got it. And just if you have to highlight one key challenge in terms of last mile delivery, not necessarily only for the tribal population, but in general, if you'd say what would be a one key challenge?
So out of many challenges, the one key challenge what I see in terms of reaching or making this last mile to be covered is offering something in their own language. First of all, informing them that this is something which exists and creating a felt need among them. Because sometimes even if we make things available, if there is no felt need in the community, the access to that care becomes impossible for them.
Wonderful. Thank you. Maybe let me just move the same question to Mr. Sanjay Mariwala. He's with Omni Health. Over to you, Mr. Sanjay Mariwala. Just the same question again I'm posing to you. What, according to you, is last mile delivery? Just wanted to get the clarity amongst all participants here. And if you have to list out one key challenge, what would it be in terms of last mile delivery of health?
Yes, Arvind. Let me attempt that a little differently from what our earlier speaker said. I look at, I think we need to divide our India into fundamentally two parts, which is rural and urban. Okay. The challenges in rural are different, the challenges in urban are different, in my opinion. If you look at the urban challenge, we have access to a lot of healthcare facilities, doctors, capabilities, clinics, specialities, everything is available. The best of the world's doctors are probably in India. Um, but we have a challenge. Okay. We have a fundamental challenge that, you look at an emergency and getting a patient from home or from his emergency place to hospital is a severe challenge in this country. Which is any city, if you look at any urban center, we have traffic difficulties. We have indiscipline in the traffic, which prevents the ambulances to make their way across to the hospital. And in the first 10 minutes or 15 minutes, if critical care is not made available to a patient, that can make a difference between life and death. Okay. So this is one key area which I think we seriously need to ask ourselves as to what are we going to do from the urban side of it. And the rural issues are a little different, and it has maybe two fundamental issues that we need to deal with. As we just said earlier, the number of doctors available in rural areas are so limited. Maybe one health center within 6 villages. So access to the health center itself is tough. Within those health centers, availability of doctors is limited, and I think that's a real challenge. And I'm not sure why we haven't come up with a different model, which is what we really need to think of. While technology helps getting information across to doctors, we can enable all that, but having access to doctors is the key. And perhaps one of the models we need to think about is how does the government system actually consider paying double the salaries in rural areas for those doctors willing to go there, and cutting the salaries by half to the in urban areas, because you have access to other ways of making money in the urban centers. Doctors have access as well to run private practices. It's a simple model like that we may have to think of, but it's just a question that we really have to confront. And in my company, we are attempting some of these challenges. We operate a lot in rural areas. We reach out to farmers across various rural sectors, and we try and provide them healthcare solutions as our CSR. And that's where we are learning some of these challenges that confront us.
Great. I think that's a very important point that you've highlighted. There are definitely multiple challenges. It's not just the rural areas. Even in urban areas, you've got a lot of challenges to reach to the last mile. So we'll go into the details as to how organizations such as yours have been dealing with that. But before we go to the specifics of what your organizations have been doing, let me also bring in Mr. Ranjib Sharma from Marks and Spencer. Mr. Ranjib, again, the same question to you. What's your definition of last mile delivery in healthcare, and what's your one key challenge if you have to pick one? Ranjib, can you hear us?
He's on mute. Okay.
Ranjib, we can't hear you.
Hear me?
Yes, we can hear you.
There you go. See, technology. Anyways, so we are talking about technology and healthcare, and technology actually acts like differently at different times. So just like I wanted to refer to what Mr. Mariwal had talked about. In terms of our setting, and both have different challenges. So I'm going to talk more about, we are a clothing company, and we had embarked upon our CSR journey, and health was one of the intervention points. And we did a experiment, way back in 2015, and it has actually come up with very interesting results. And it is something which we did actually in the urban setting. So if I may use the word that, what role, so I'm going to be talking about what role CSR can play in technology and model building. I mean, you have to actually create a model which is scalable, replicable, and of course that, technology can be used as an aid. So, coming back to your question, there are some statistics, for example, talk about in urban low-income areas, that's a particular place which we chose, like Muhammadpur, there, near Gurgaon. Now, generally, if you talk about the statistics, we have around 50% of the children and women who are malnourished. Most of them, they are suffering from anemia. That's one fact. Around more than 3,000 children in a population of 10,000 are at high risk of blindness. So, uh, all of which is like treatable at the community level. There may be 5 to 9 episodes of diarrhea we see every year, which lasts around 4 to 7 days in each family. So which means lack of basic facilities like safe water and proper sanitation, leading to these conditions. So these are the statistics, and then these statistics have actually implications. For example, and then especially for the poor, which means repeated episodes of same or similar conditions, which can be avoided actually. Then they have to live with undiagnosed chronic conditions until they are serious. Poor quality of treatment leading to longer term issues like drug resistance, significant out-of-pocket, or getting caught in an health and poverty gridlock. So when we actually did the intervention way back in 2015, we went with a sole purpose. When we did the needs assessment, we saw that that population was actually not accessing the formal healthcare. So initially it was very clear that okay, let's focus on the formal healthcare. But then over a period of time, we did realize that there were challenges when we actually started educating them about the importance of formal healthcare instead of going to informal practitioners, because of which, for example, you have issues like undiagnosed chronic conditions and the other things. But we saw a kind of resistance, and this is where the challenges also came in, because people went in, and people within a month we saw a big resistance. Like people they didn't want to go and access the formal healthcare, maybe because of lack of I think required number of health professionals, which are very, very less. Second is in terms of the accessibility. So these people, the ease of, for example, accessing the formal healthcare, which is a big challenge. And third is, of course, lack of instant gratification, because you have to go through a process.
Okay, got it.
So this is the challenge we found.
So great. So there's a lot of challenges that you have highlighted. One is the access. Maybe even if they go to the access, their doctors' availability has been a challenge. Sometimes the local providers are quickly available to them, so they go there. But sometimes it also happens that the local providers may not be fully qualified. So then the after effects of not getting a complete and qualified treatment is also a challenge. Good. So thanks. So a couple of points which are coming is that this is very relative. Last mile is for different populations, could mean different things. Challenges are there for both urban as well as rural. We may have to contextualize solutions according to their populations and the geographies. So maybe let me start this time with Mr. Sanjay Mariwala. Mr. Mariwala, you were actually specifically speaking about solutions for largely focused on rural populations, if I got you rightly. Can you sort of briefly explain a little bit more about your solution, or what is the type of support through CSR or technology that you have programmed for the rural populations?
So what we do is that we work in extremely rural areas, farming lands, farming areas, and we have over 15,000 farmers who contract with us on their crops, which gives us access to not just those 15,000 farmers, their families and their villages and their larger constituents in and around that area. So we kind of reach almost 50,000 potential patients who need help in healthcare in some way. And we look at the rural areas and we look at the problems in two parts. One is critical care, which is related to some significant disease that they are suffering from. It's cancer, maybe it's cardiac conditions, maybe it's something very serious that they're dealing with. The other is routine chronic care, which may be dealing with fundamentally three basics that we talked about, Ranjeev talked about, which was to do with anemia in women, diarrhea in children, and blindness in both men and women. And I think these are three very significant challenges we see on the ground, and we address these three as a part of our CSR programs. What we have attempted to do is to we have technology at use in our farms. We have each of our farmers mapped out on a phone. We have each of them has a we have given them an Android phone, and they are linked to our servers, so they not only have information access to our crop advices and looking after their crops and making sure that the crop that they are growing for us is well managed and looked after. But if they have an emergency of any kind in medical, they can reach our agriculture team that connects with our CSR team and ensures that a crack team is rushed to the spot for any particular emergency that we can help them with. The other thing we do is we have created since access is limited and facilities are limited, we have created mobile facilities that we have tied up with institutes like the Arvind Eye Care, for example. They come and run camps for blindness and spectacles and cataract, and operate in the villages. We set up mobile hospitals, and we operating theaters, and they operate there, and we provide them those access to those facilities. Similarly, we ran a very interesting program on evaluating the anemic health in women, and we found there were so many of them suffering with anemia. They didn't even know that this was a challenge for them, and all it needed was education, awareness building, certain amount of access to the right kind of vegetables and food that was nutrition, which is important. And we've got that sorted out at least in a number of villages that we are present in. We still have a lot of ground to cover, but we are hoping that our CSR program will achieve this. The most interesting learnings we had was when we started talking to the children, because when we started introducing just a simple hand washing program, the results that we got out of teaching children to wash hands before and after every activity made such a big difference that today it has also stood them great in the face of COVID. It has given them great protection. Washing hands with soap and water. Not only have they done it well, they've also trained their own parents on how to do this right. And that's been a huge learning for us, and it's been a great development. Coming to how technology can be used, I believe we can bring doctors to use the technology that can address some of these critical care patients as well, while looking at them, referring them to the doctors through telemedicine. But I think what is more necessary at this point in time is to be able to create solutions that can help reach the care very quickly to the patients, and that's probably what is not happening. I think we are still at that stage in this country, in India, in rural care, and I think that's really what we need to bridge very rapidly. So where technology can help is kind of bring the cost down of establishing centers in each region, and somehow getting doctors to those technical centers is what we really need to achieve and do. And I think that's what we are looking after. We are looking for as solutions, and hopefully we'll find something interesting to work with as a CSR activity ourselves.
Wonderful, wonderful. I think you bring in a lot of valid points, and you have actually highlighted how you have used the local resources there to effectively address some of the critical issues, whether it's using the farmers, forging partnerships with organizations like the Arvind Eye Care Hospital, using technology, and even using children as advocates or influencers. That's a great approach. Mr. Ranjit, you mentioned about solutions focused largely on urban health, urban programs. Can you give a little bit more details about your program, and specifically what type of technology support that you have used, and a little bit more about your CSR interventions? I think you're on mute, Ranjit.
Sorry. Yeah, can you hear me?
Yes, we can hear you.
Yes. So continuing with the initial discussion, when I mentioned about the challenges faced. So what we did was in the next year, And then that is what I think exactly we did, with a partner NGO. I mean, it really helps, and we gave them, a free hand in experimenting and then finding the right, model, because this is where I think we talk about technology and creating the right model. Because what happens is Mr. Mariwala also explained, there are many innovations today. And what is the challenge? That they don't come together in a meaningful way for transformation to occur in the lives of the poor and marginalized. I'll give you an example. Like if you look at a poor migrant construction worker, it is not about just health or income or education for her family. All of these are essential and must be available simultaneously. You cannot look at the same thing in silos. And then this is also the reason we have the 17 SDG goals. We cannot achieve the goals one by one in a linear manner. So basically, we have to look at different things coming together, because if you talk about health and well-being, the other aspects also need to be looked at. So that's why we embarked upon setting up a wellness center, in the heart of that village. And it's actually called the I4V, or it's also called the ICHW, which is called Integrated Health and Wellness Program. And the idea was to actually create a model and a platform that can actually create impact, sustainability, like in a sustainable way. So if you look at the model, it looks like something like this. I don't know if I can actually share my screen here. You.
We can see a screen.
See my screen now.
Yes, we can see a screen.
Yes. So do you see that? That what is the overview of the whole model? So the system is actually focused on primary care, and then of course you have a navigation that's supposed to the secondary and tertiary care. Then there are 8 free benefits. And then, we wanted to actually create a sustainable mechanism also, so that on one hand you have free accessibility, but at the same time, you have some kind of self-financing model, which actually creates a pull factor, instead of because I think there is an age-old saying about you offer something for free, people do not appreciate it. So there needs to be a sense of ownership. And then how can the communities actually what they can experience? So one is of course prompt and empathetic and quality care for express illness locally, which is actually direct interaction. So we have actually put up a nurse there. Then we have also put in telemedicine. So the second is of course screen and treat 10 high burden conditions, like we mentioned, anemia being one of them. Then also prevent illness and promote wellness through a range of actions. So again, as I said, simultaneously we have to actually tackle the issue. So like for example, we also went to the schools where we taught about the importance of hand washing, and so currently and then also the important thing about how do we blend it with the financial financial model, and how can we actually over a period of time we have to look at an exit strategy. So in 2015 we actually invested 100% there, and once the model was created, so how it was actually replicated. I mean, I think that is the next question you might ask about the sustainability. I just thought I'll preempt this question. So it was actually to create a self-financing model, and also not only us as a brand, we would have an exit strategy, but also the NGO that is actually implementing it, so that the community becomes self-sustainable. So this is how the model looks at. And then if you look at the other aspect, the technology part. So for example, can you see my next screen? Technology is necessary. Yeah. Of course, how do you scale and transform necessary in India cannot be enabling the technology. So it is very important for standardization. Second is point of care diagnosis and similar device innovations are which will allow care and close to person at home. That is also very important. Like we said, the inhabitants, they had a lot of issue actually accessing the formal healthcare. Maybe they had to walk for maybe a kilometer. Then of course they are faced with overburdened doctors who are very rude, and also in terms of availability of the services. So and then that's why, on the other hand, informal healthcare service provider is just sitting next, next door, and the person can go. So it's important that how do we actually bring in the technology through the diagnosis and the medical facility nearer home, and then of course, looking at the cohorts of people who need care over time, like type of monitoring requires, how do you use the technology. So that's why we also recruited 5 health facilitators, from within the community. So the community could also relate with themselves. They were able to actually explain to the community why it is needed. And the interesting bit was that we also found other issues, which also led to the next big question about not only the physical health, but what do you do about emotional health or mental health, because for example we saw instances of child sexual abuse, for example, or domestic violence. So how do we actually then cater to these issues also? So for that we also set up a legal center for them. So this was a 3 or 4 pronged strategy. And today, in terms of sustainability, we have actually around this model is replicated around 40 centers. And obviously, we didn't have to pay for the whole model. We just invested in the initial model along with the organization. They also brought in their expertise. And then today we are also open to partnerships with other organizations. For example, in maybe Bangalore, for example. A whole area was actually given to Levi's. So Marks and Spencer and Levi's, we might be in different positions in terms of when we comes to business, but in sustainability, we thought of cooperating together. I can talk more about it, of course, but this was something I wanted to actually point towards, that how can you actually sustainably take a model forward and use technology.
Yeah, great. So this is helpful. Ranjeev, to get a full perspective of your programs. And the 2 key messages that I picked up from your brief is that the importance of holistic programs, while it is critical for key services, but you may want to definitely meet so giving them a holistic approach, the need for us to sort of think of sustainability right from the beginning, and your combination of some services being given free and some services being charged, or bringing together sustainable blended financing arrangements, something very, very interesting. And in fact, USAID is partnering with the National Health Authority also to come out with something similar, a blended financing facility. It's a $100 million project focusing on largely COVID at this point of time. So that's one very interesting. But before we go into the details, I wanted to get Mr. Prabhat's views, because I was speaking to him today morning, and he had a very interesting model of reaching communities not through regular programs, but he has a different initiative altogether. So maybe Mr. Prabhat, if you give your experiences of the new approach that you've taken to reach communities, that would be very helpful.
Thank you. First of all, it's great to listen from Mr. Rajiv and Mr. Sanjay, is 2 really good models how it is helping community. Now, what I'm going to talk about is not very fancy; it's very basic. When we talk about healthcare, one of the important component of healthcare is patients. And patients in India, if you see in any disease area, largely they have been a very passive participant in this entire discourse. Now, and of late, there also has been a lot of organizations which are of the patients, by the patients, for the patients, which is patient organizations or patient support groups, we call it. In India, you don't find many, but still there are sizable number of very, very good groups that exist, and they do some commendable work on ground. And why I'm bringing this issue, and they are technically, they are non-profit organizations, they are NGOs, but they are the groups who have been largely been affected themselves. Either it's a parent group or a patient's group. The reason why I'm sharing this model is, and it's more than a model, it's an approach that at Novartis we piloted and started in 2015. With the basic premise is that in these disease area, the need is going to be there. Now, how do we as an organization, as a corporate, move from provider to enabler? How do we start empowering, putting our effort to empower these groups while we continue doing some service delivery efforts? But is there any merit in piloting something where we truly believe in empowering these groups, building their capability? Because today, the kind of situation we are in, whether it is in terms of funding with changing FCRA rules, every second day, non-profit organizations who relentlessly work on ground, they face newer challenges. They really struggle to continue a lot of work because of the funding priorities being changing and all those things. Now, for them, it is very important to be updated. They need to be trained. And the program, what I'm going to talk about is an approach. So in 2015, we collaborated with SP Jain Institute. That if SP Institute like SP Jain, one of the premier institute giving business education, can create business leaders, create bigger sustainable organizations for profit making, can they share the same expertise with leaders of patient community or so-called non-profit organizations and build their capability, help them to make a stronger organization? 2015, we started with one disease area called thalassemia. We brought 30 such individuals, leaders, patients, parents together at SP Jain campus for a 10-day program. This program called Saksham, which is truly a kind of a short capsule course, in campus course for 10 days. These people come together from different places, stay in the SP Jain campus. 10 days they are being oriented on different aspects, from leadership, from finance, from social media uses, and from the best of the faculty at SP Jain. They learned courses like design thinking, for example. Now, why I'm saying these different components, because it helped them, first of all, to come together as group of organizations from various parts. And for last 5 years, we have done this training repeatedly, this course in different disease areas, started from thalassemia to sickle cell disease to cancer to rare disease. And what we were amazed to see, the capacity and the potential that each of these organizations have. If we want to talk, and today's context is also last mile connectivity, and in that last mile connectivity, if you want to reach to that last person who is affected by the disease, there cannot be a better legitimate organization who is led by these people, because they had passion all the time, they had purpose all the time. What they lacked is the process. And I think investing in this process, which is not as tangible as many other programs, but the result on ground, what we get when these 60, 70 leaders, well trained, what they have done, and they own the result. The role of Novartis or role of SP Jain has only been a catalyst role. But when we see these organizations creating bigger impact on ground, a part of it they learn from this course in Saksham. And I think these kind of things, and one example, for example, social media uses. Now, everybody is passionate about social media, but it's an ocean. To use social media effectively, and to, I was watching one session on the same platform earlier this morning about communication, strategic communication. How important is for a small NGO or a big NGO to ensure that they use social media optimally? How do they know that the organic has no meaning nowadays? Everything is paid on even on Facebook, but how do they use these platforms efficiently and effectively to reach out to more people? And I think these all are learnings that they need to get. They cannot afford to, hire a big PR agency or a big social media agency to do this. They need building their capabilities. So I think this whole approach that we piloted starting from 2015, I think it says that when we talk about last mile connectivity, it is not only technology, it is not only about infrastructure, it's the people. Individual also plays a very, very critical role. So that's all at this point of time. Over to you, Mr.
Thanks, Prabhat. That's a very, very interesting dimension you're bringing to the whole discussion of building the capacities of not only institutions but also individuals and this patient support groups as a body, not just the technical information alone, but giving them the capacities of leadership, communication, soft skills. Those are really interesting aspects, and I think you rightly also highlighted that corporates need not be always seen as funders and providers, but the positioning as an enabler also is also very important in these current situations. I think this is good. A lot of insights. All of you have got different dimensions to how we can reach to the last mile. My quick question to you is that as organizations, there are a lot of successes and some challenges also. I wouldn't say all of them are successes. Every programs have got their own challenges, but there's a lot of good work that all of you have done, and it's been done. Some of the organizations has done it at a scale. Some of them are just starting at a smaller level. My key question is if organizations have to consider sustainability and scale, what should be the key factors that need to consider? I know that a lot of effort, but there's also a saying that pilots never fail and pilots never scale. So there's a lot of investments that's being made in the pilot programs. A lot of effort is going there. Now, the key question is, how do we scale it up? What should be the factors that we should consider for taking it to scale? And what would be the possible role of organizations, corporates, the government, as well as the development partners and donors should be in assisting in such type of successful efforts to be scaled? Over to you, probably Ranjeev, if you can start, and then we can move to.
Sure. Thanks. In fact, just to let you know, I have to leave in another 10 minutes. So yeah. So in fact, I had already touched upon what we have done, from a practical viewpoint, where we did partner with competitors also, and then maybe competing stakeholders partnering in non-competitive areas. So the idea was like, how do we actually take it to the next level and how do we replicate the model? So one of the areas of sustainability, because I think when you take it to the next level and then when you actually scale up a pilot, it means that, first the pilot needs to be proven to be self-sustainable. So how do you sustain? I think, the gentleman before me, he had already talked about it. And, it's, for example, as organizations, how do we aid a community to actually and then guide them to be sustainable? So what we did was actually we set up, a village committee, from the village, and they were, and it's kind of a federation, which actually is now actually taking the responsibility for scaling up. The other thing is that, for example, it always helps for corporates like us that, if we have interesting ideas and the idea is to actually replicate them and scale them up. So it's important to actually free your existing resource. I mean, you do not then, continue doing one thing every year. So over a period of time, when we saw this model grow and we took it to a particular level, we thought it's time for its replication and also invest in something new, and so that's why over a period of time, we had clearly discussed with the our NGO partner that while this model actually goes to the next level, it's also important that we also together pitch for independent organizations to actually invest in this thing. So that's why for example, even if the amount is less, and then of course themes. So what happens is there are ways one could be that okay, we actually invested the whole thing in a holistic manner. But for example, there's another brand who wants to do, and then in their objective, the focus is more on, let's say, looking at only one aspect, that is perhaps providing livelihoods. So like we said, okay, fine. I mean, let's actually create a a module within the bigger program which actually supports livelihood. So the partnership goes in that. So what happens is that, over a period of time, our resources, the level of our investment, they come down. And then, we also partner. So it's kind of a joint ownership. So here, it's not that, the relationship with the NGO service provider is not about we are a donor and they are the ones who are actually implementing. It's of an equal relationship where they bring in the expertise. They also bring in additional resources, funds, for example, tapping on independent donors like USAID or Give to Asia. So where they and then as a corporate we then match fund it. So what happens is that the pot of money actually becomes bigger and we are able to do more things. And similarly, so that's why and then we don't as a corporate just hold on that, okay, we were the pioneers of this particular model, so we will hold on to it and will not allow others to do it. So it's the focus should be more collaborative. That's how that you'll be able to look at the organic growth of a particular concept. And this model actually has actually grown and developed over a period of time and with different focuses. So right in the beginning, we started with something that the intervention was all about diverting people from to a formal healthcare system to setting up a wellness center. Now the wellness center has become the hub where we have actually put in a psychologist, we have put in a nurse, we have got in telemedicine, and also we have put in a legal aid center. We are also helping people there, for example, connecting them with the government services. So, and then in fact, interestingly, we did a SROI and it was around 300%. So it actually gives us a lot of confidence and motivation to actually scale it up and even motivate other donors to also participate and own it.
Yeah, wonderful. I know that you'll have to leave, but just if you can stay for a few more minutes, I think what you're bringing is a very important point of alliance formation. And I think there are different organizations doing differently. For example, I know that even USAID, when we start corporate TB pledge alliance, so it's just not one organization. We have about 105 organizations now today collaborating on eliminating TB in India. And that's a very tired approach. We have got companies to join as a silver, gold, platinum, and diamond, and each of those levels contributing in different form for the particular problem. So even within a geography, a silver member may be just saying that, okay, we will do only this, whereas a platinum member or a diamond member who is joining the corporate TB pledges in alliance says that, okay, we can go beyond this, and it's not only CSR, they also become champions for a particular cause. So you're right, alliances formation for any team is a big opportunity, and several organizations need not be only donors and government, but I think even I know, for example, State Bank of India now has recently formed a COVID alliance. There are many alliances like that. So that's a good point. Let me just move now quickly to Dr. Sanjay. Sanjay, do you have any points on what should be the key factors that should be considered for scalability of proven models? And do you see any potential roles, or do you see any models which could be considered? And also the role of USAID or donors or government in supporting this.
So there are many ideas. We've been working on many pilots. As you rightly said, pilots are the beginning of new ideas and new concepts. I think there are a couple of things I think I can bring to the table today, which we are attempting right now. Take an example of, you talked about technology, how it can be a tool to make this work. So one of the things what we are trying to do is, can we, the access to doctors again in rural areas and technology, how do we bring these two together to create scale by which a doctor in one particular region or location can reach through connect with e-patients who are enabled through an app maybe, and through that cell phones or mobile phones. How can they connect with the doctor and solve their issues very quickly? This is one model that can scale quite rapidly because everybody today has a smartphone. Even the farmers today want a smartphone. We have actually distributed many smartphones. How do we then use that effectively to make this work right? So that's an attempt we are going to attempt to make, to see how we can link it through our app, the doctors, and one doctor in a 6-cluster village to all the patients in that area. So this is one model that could be exploited, is what we are exploring. The second model, which we have actually succeeded very nicely, is with the PPP model and public-private partnership. We noticed that the PHCs have certain testing mechanics, but I think they don't reach out, and they expect patients to come to them. Uh, One of the things we have done is partnered with them to take the tests out and got this kit, supported them with kits, rapid testing kits for anemia. And we figured that when we ran it through 6 to 10 villages, we found almost 36% of the women had anemia in all those villages. Okay, and they had not been tested, because you see the priorities in rural areas are different. Do you want to spend money on testing? I don't think anybody wants to spend money on testing. How do we get testing to them is going to be the other model that we need to build through scale, and thereby figure out, and the way we do it is our agriculture staff that visits those villages actually gets this rapid test done and then posts the results on the phone back to the PHC, and we get a validation that yes, this is an anemic patient and we need to do something about it. The PHC has all the facilities. The government is willing to distribute lots of medicines, but it's just that patients are not getting it. How do we build that partnership with the government to make sure that we become the vehicles through which the aid reaches the villages which we are already operating in? These are the couple of things that we are attempting and trying to do, because this is what is really happening at the grassroots levels as we see in rural Karnataka, for example.
Thanks. One quick question. While technology is definitely an enabler and really making a big change, there are also certain populations who are unable to access these technologies. Whether they don't have smartphones, or the phones are controlled by their male members in the family, or they are not literate. So as corporates, when you are investing in technology, particularly on smartphones and app and other types of technologies, what type of factors do you consider to make sure that such audiences are also not missed out in your?
Yeah, it's an excellent question. It is a real. Actually, there is a genuine problem here, and it needs to be dealt with effectively. And when you're communicating with the audiences by trying to increase your depth of communication to make it relevant to people to understand that this is not just a phone is not a tool only for the business of the man. Okay, it is really a lifeline to the whole family, and I think how do we encourage that is really what we need to bring out for them. This is critical of critical importance. It's a tough job to do. You are absolutely right. This is what we really need to spend a lot of time and effort on.
Sure, thanks. Prabhat and Ranjit, do you have any suggestions on that, or we can move for the question and answer sessions from the participants?
Sorry, go ahead. Please go ahead.
Go ahead, Rajiv. So I just wanted to say, see, the whole healthcare ecosystem in country is in transition. It has changed and it will change. And we have to acknowledge that, and we have to start getting ready for this change. And one of the change is Ayushman Bharat, which is PMJY program. We can continue deliberating what bad, what wrong, what good, but at the same time, this is a health assurance program which gives me assurance to access healthcare service, insurance for 5 lakh rupees in any of the center. Also, there is another component which is health and wellness center. Now, why I'm quoting these two examples is, again, the role of many of the organizations and as corporate to help somebody, some NGOs, some organizations to work on that. We may not be able to, maybe provide the services to a particular segment or geography, what we can do from our resources. But as Mr. Rajiv rightly said, is that it's a role of collaboration, it's a role of partnership, and using the existing infrastructure that exists, that is being developing. And I think in that way, scale up of things will start happening, and to invest for things which has not been covered by existing system. So for things which is already, I'll give an example for cataract surgery, for example. I used to work for an eye care international NGO at some point of time. Now, at that point of time, paying for one cataract surgery was essential. Now, government is ready to pay, a very good substantial amount for one cataract surgery reimbursement. Now, do as a corporate, do as an NGO, we need to, duplicate the effort. Or I start putting my effort for some disease area which may not be covered as part of blindness program. Maybe it's a diabetic retinopathy or glaucoma or refractive error, but not investing for cataract. Rather, in cataract, helping these NGOs to tap fund from Ayushman Bharat or PMJY. So again, it's reducing duplication, using existing resources. I think is going to be the key, and being prepared with the changes that is happening in the ecosystem, be it National Digital Health Mission, be it PMJY, because these are going to transform the healthcare system in next few years.
Okay, wonderful. I think we have about another 5 minutes time, and there are a couple of good questions that have come. So it's not pointed towards any particular individual. Let me read out a couple of questions. Um, Sorry, I think there is some challenge in my system. I'm not able to move the.
Which question you're referring to?
I'm just give me a second.
Uh-huh.
So there's one question here from Somin Lari. It's, I think, two questions here. I put both the questions. We have developed some telemedicine concept, but how to make sure of connectivity challenges, rural awareness, and sustainability? This is one question. A second question is, one big challenge among asking people think using technology will reduce pricing, but how to make them understand use of technologies to provide right services or empowered rural areas and not to reduce pricing only. So any of the panel members, would you like to answer those questions? Okay, there's also one question. Should the panelists list out 3 important areas of healthcare intervention to the post-COVID world for children, women, and the poor? Maybe this is a question which is probably very generic and open to any of the panel members to take it forward.
So let me answer this third question of post-COVID. I think 3 things which comes to my mind. First is decentralizing care. The first thing which has to be a focus is bringing care closer to community. Patient need not to come for a chemotherapy from a village in Baripada district in Odisha to Tata Hospital in Bombay. And we have seen that things doesn't work in that way. So bringing even the specialty care closer to community is one. Second is the communication. And we have seen even putting a message, whether it is social distancing and all, it's the creating a right channel of communication. And the third is using appropriate technology. It is not only about using fancy technology, what we feel it's going to work. It's using a technology which is more suited to that particular area. I think these would be the key areas from my side, and others can add to this.
Yeah, and quickly, I have to just leave in just 1 minute. So just wanted to highlight the methodology which we employed. In fact, one of the things which we did in during the COVID times was in-kind contribution in the form of e-volunteering. I mean, this is something in which we encouraged our other employees, not the CSR ones, but the other employees to actually get into e-counseling. In fact, we had some very, very disturbing inputs from the inhabitants of the village about with suicidal tendencies, about issues related to this is something which can be actually used through a helpline, and the services can be brought to the people who are in need in case of mental health. The other thing is also for example, if you have a wellness center and the center is actually functioning in a way, and it has got the facilities in terms of telemedicine and other facilities. So even people who do not have access to the technology, like absence of smartphones, they can actually get instant benefit from such centers. So, and also and I agree with the point that obviously technology is to be looked as an enabler. but at the same time, to actually get its acceptability, we have to, in a way, in the initial stages, subsidize it, but slowly also, like, make people aware that, why it is important that, we use technology. And I think in post-COVID times, this is going to be the reality in coming times. So thank you so much, Mr. Arvind and all the other panelists.
Thank you. At the close of our session, so I wanted to thank all participants. I think all of you gave some excellent insights, whether it is the using of strengthening the capacity of institutions, the importance of using technology, the role of CSR in programs. I'm sure that each of this would have a detailed discussion to be done. But I think we tried to sort of combine all these things in one meeting, one session. So once again, thanks all the panelists for the great responses. Excellent work you have all been doing. Let's stay connected. Over to you, Yasmin, from us. Thank you so much.
Thank you.
Thank you very
Thank
much.
you, Mr. Kumar, for your wonderful moderation. And I think a big thank you to all our other speakers for a truly riveting dialogue around healthcare.